Welcome. I hope you're having a great day. Adverse drug reactions are defined by the World Health Organization as any noxious, unintended, and undesired effect that occurs at normal drug doses. Thus, they exclude excessive dosages. The reactions can range from annoying, such as itching, to life-threatening, such as anaphylaxis. Adverse drug reactions are most common in the elderly and the very young, and those who are severely ill. There has been a dramatic rise in adverse drug reactions. More than 800,000 outpatients sought emergency treatment for adverse drug reactions. In hospitalized patients, more than 1,700,000 experience adverse outcomes as a result of drug reactions and medical errors. Of these events, more than 53,000 have died. Remember, these data are from 2011 and could potentially be higher. Many of the adverse drug reactions were preventable. There are two types of drug reactions. Type A reactions are common and predictable. These reactions include side effects and drug interactions, as well as overdoses. Type B reactions are immune-mediated, rare, and unpredictable. As nurse practitioners, we are mostly concerned with immunologic reactions or allergies. Let's go over some definition of terms. A side effect is a nearly unavoidable secondary drug effect produced at therapeutic doses. It may develop soon after the drug is initiated or not until the drug has been taken for weeks or even months. A common example is drowsiness with diphenhydramine. A variant in time example is with angioedema, often caused by an ACE inhibitor. This reaction can occur soon after beginning the drug or not until months or years later. Toxicity is an adverse drug reaction caused by excessive dosing, but may occur with normal dosing. Drug toxicity is a common and significant health problem, yet it often goes undetected by both patients and healthcare providers, who don't suspect it as the cause of such symptoms as mental disorientation, dizziness, blurred vision, memory loss, fainting, and falls. Although drug toxicity may result when a medication dose is too high, it can also happen because a person's ability to metabolize a drug changes over time due to changes in kidney or liver function, a change in health status, or an addition of another drug that changes the first drug's metabolism. An allergic reaction is an immune response determined primarily by the degree of sensitization of the immune system rather than by drug dosage. The reaction can occur the second time the drug is administered or the 200th time. The patient's sensitivity to a drug can change over time. They can become more sensitive or less sensitive. Very few drugs cause severe allergic reactions. Penicillins are the most common, but also sulfonamides that include certain diuretics such as thiazide diuretics like hydrochlorothiazide, antibiotics such as, it's easier just to say Bactrim, but it's sulfamethoxazole and trimethoprim, so it's SMX and TMP, which is Bactrim, and oral hypoglycemic agents such as the sulfonylureas like glipizide. Idiosyncratic drug reactions may be defined as uncommon adverse effects that cannot be explained by the known mechanisms of action of the offending agent. They do not occur at any dose in most patients and develop most unpredictably in susceptible individuals only. It sometimes results from a genetic predisposition that are immune mediated. One characteristic that's common is a delay between starting the drug and the onset of symptoms. Examples of idiosyncratic drug reactions are triglyceride-induced liver failure, often leading to death or liver transplant, clozapine-induced agranulocytosis, which is an essential type of white blood cell that suddenly disappears, making the patient susceptible to infection, and sulfonamide-induced toxic epidural necrolysis, a very severe skin rash, much like a thermal burn, and treated in a burn unit. This type of adverse drug reaction is responsible for a significant number of deaths, and their unpredictable nature makes them virtually impossible to prevent. A paradoxical effect is the opposite of the intended drug response. A common example is when using benzodiazepines for sedation to treat insomnia, where excitement may occur instead, especially in children and older adults. Iatrogenic literally means a disease produced by a physician, but it is also used to refer to a disease produced by drugs. For example, drugs for antipsychotic disorders can cause Parkinson-like symptoms. It may also be called a drug-induced disease, as the disease is essentially identical to naturally occurring pathology. Physical dependence may develop during long-term use of certain drugs, such as opioids, alcohol, barbiturates, and amphetamines. It is a state in which the body has adapted to drug exposure in such a way that abstinence syndrome will result if the drug use is discontinued. It is important to warn patients against abrupt discontinuation of any medication without first consulting a knowledgeable healthcare professional. Dependence is different than addiction. Okay, the last couple of terms related to adverse drug reactions are carcinogenic effect and teratogenic effect. Only a few therapeutic agents are carcinogenic, and some drugs used to treat cancer are among those with the greatest carcinogenic potential. Patients who have been treated for cancer are often at risk for developing other cancers due to the treatment. Evaluating drugs is difficult. It may take decades for evidence of carcinogenesis to appear after exposure. An example of this is diethylstilbestrol, DES, which is a synthetic estrogen that was developed to supplement a woman's natural estrogen production. It was first prescribed by physicians in 1938 for women who experienced miscarriages or premature deliveries. DES was originally considered effective and safe for both the pregnant woman and the developing baby. In the United States, an estimated 5 to 10 million persons were exposed to DES between 1938 and 1971, including women who were prescribed DES while pregnant, and the male and female children born of these pregnancies. In 1971, the Food and Drug Administration issued a drug bulletin advising physicians to stop prescribing DES to pregnant women because it was linked to a rare vaginal cancer in female offspring. Women exposed to DES before birth in the womb, known as DES daughters, are at an increased risk for clear cell adenocarcinoma of the vagina and cervix, reproductive tract structural differences, pregnancy complications, and infertility. Although DES daughters appear to be at highest risk for this clear cell cancer in their teens and early 20s, cases have been reported in their 30s and 40s. Teratogenic effect is a drug-induced birth defect. A common example is isotretinoin, which is used for severe acne. That causes severe teratogenic effects such as serious craniofacial, cardiovascular, thymic, and central nervous system malformations. The tranquilizer thalidomide is one of the most famous and notorious ones. This drug was used widely in Europe in 1959 for pregnant women with nausea, after which an estimated 7,000 infants were born with the thalidomide syndrome or meromelia, which they were born without arms and legs or very short arms and legs. The pie graph depicts the causes of congenital malformations. Drugs and medications cause less than 1% of the total number of congenital malformations. In general, be alert for patients with new medications, dosage change, or recent health change that could change a tolerated interaction to a clinically significant interaction. For example, an additional CYP450 enzyme inhibitor or inducer, or increased renal impairment. Older age and polypharmacy are risk factors for clinically significant drug interactions. Over 80% of patients taking 7 or more drugs are at risk of a drug interaction. Watch for interactions with drugs that are strong inhibitors or inducers of drug metabolizing enzymes or transporters, such as clarithromycin, carbamazepine. Watch for interactions with drugs with serious dose-dependent adverse effects or narrow therapeutic index drugs, such as statins, calcium channel blockers, methotrexate, colchicine, oral anticoagulants, atypical antipsychotics, ergos, opioids, antiarrhythmics, digoxin, warfarin, levothyroxine, lithium, theophylline, etc. Watch for these interactions with drugs that can increase the QT interval. Use of more than one QT prolonging drug increases risk. Watch for interactions between opioids and drugs that cause respiratory or central nervous system depression, such as benzodiazepines. Watch for interactions that involve drugs that can increase potassium levels, such as SMX-TMP, Bactrim again, ACE inhibitors, ARBs, potassium-sparing diuretics, or aldosterone antagonists. Watch for interactions that could result in reduced efficacy of medications which reduced efficacy is not obvious until treatment failure occurs. For example, enzyme inducers with contraceptives, hepatitis or HIV antivirals, chemotherapy, anticonvulsants, and anticoagulants. Watch for drug interactions involving serotonergic drugs. When considering the clinical significance of a potential drug interaction mediated via metabolic pathways, Keep in mind that just because a medication interacts with one substrate of a particular cytochrome P40 pathway does not mean it affects all substrates of that isozyme. Genetics, age, nutrition, stress, liver disease, hormones, and other endogenous chemicals all influence drug metabolism. Additional influences include drug dosing, including the dose, timing, sequence, route, duration, concomitant medications, potential for a concurrent pharmacodynamic interaction, and specific drug features such as a narrow therapeutic index, the side effect profile, and multiple metabolic pathways. For example, most drugs metabolized by the CYP2C8 have alternate metabolic pathways, so inhibition of just one pathway might not be clinically important. It is prudent to use any combination with potential for interaction with caution, and that means to use conservative dosing and appropriate monitoring, especially those involving drugs with a narrow therapeutic index and or potentially serious dose-dependent side effects, such as chemotherapy, cardiac medications, anticonvulsants. There are two main families of drug transporters. One is comprised of P-glycoprotein. P-glycoprotein is found in the gut, liver, kidney, blood-brain barrier, and cancer cells. It pumps drugs out of cells and into the gut, bile, and or urine for excretion. P-glycoprotein can be thought of as a defense against potential poisons. P-glycoprotein inhibitors may increase levels of P-glycoprotein substrates, and P-glycoprotein inducers may decrease levels of P-glycoprotein substrates. For most P-glycoprotein interactions, the CYP450 enzyme inhibition or induction is also involved, and many P-glycoprotein substrates are also CYP3A4 substrates. Keep in mind that P-glycoprotein inhibition potency in patients is not well defined and is unknown for many inhibitors. It is prudent to use any combination with potential for interaction with caution. Again, that's conservative monitoring, appropriate dosing, especially those involving drugs with a narrow therapeutic index and or potentially serious dose-dependent side effects. For drugs or drug combinations that are both substrates and inhibitors, the net effect is difficult to predict. In opposition to B-glycoprotein, which is an efflux pump, are organic anion transporting polypeptides, or OATPs, which are uptake transporters. They transport drugs into cells. Like P-glycoprotein, they are located in the gut, liver, kidney, and blood-brain barrier. Patients can have varying OATP activity due to genetic variation. For example, reduced responsiveness to monoleucast, which is singular. It's associated with a variant of the gene. Such genetic variation can influence susceptibility to drug interactions. Please see the chart, Alcohol and Drug Interactions, for recommendations regarding alcohol consumption with various medications. We will discuss strategies to help minimize levothyroxine and food interactions in another module. See the handout for potential drug interactions with grapefruit. It lists oral drugs or drug classes that have been studied with grapefruit or are predicted to interact with grapefruit based on the drug's pharmacokinetics, and explains potential clinical implications. For information on these interactions, and especially with the fruit juices, see the handout for the OATP drug interactions. Optimization of medication administration timing may minimize or eliminate these interactions. Please see that handout also. Many drugs are toxic to specific organs, such as the liver or heart. Common examples include the kidneys may be affected by amphotericin B, an antifungal. Tubular damage is a well-known problem associated with amphotericin B, but acute renal failure is the most serious complication. The heart can be affected by doxorubicin, which is adriamycin, an anti-cancer drug. It causes cardiomyopathy. I have had patients die from this. The lungs may be affected by amiodarone, an antidysrhythmic. It is not known whether the drug problems caused by amiodarone are due to direct damage by the drug to the lung tissues, to an immune reaction to the drug, or to some other mechanism. The most common form of amiodarone lung toxicity is a chronic diffuse lung problem called interstitial pneumonitis. The inner ear can be affected by aminoglycosides, which are antibiotics such as gentamicin or tobramycin. These are usually only given topically in primary care, but aminoglycosides appear to generate free radicals within the inner ear, with subsequent permanent damage to sensory cells and neurons, resulting in permanent hearing loss. Hepatotoxic drugs are a leading cause of liver failure in the United States. More than 50 drugs are known to be hepatotoxic. As some drugs undergo metabolism, they are converted to toxic products that can injure liver cells. Combining hepatotoxic drugs may increase the risk for liver damage, for example, acetaminophen and alcohol. We usually do baseline liver function tests prior to initiating a hepatotoxic drug. AST and ALT are monitored for liver injury. We no longer monitor the liver with statins except for the baseline liver function tests and if symptoms appear. So watch for signs of liver injury. Educate patients about jaundice, dark urine, light-colored stools, nausea, vomiting, malaise, abdominal discomfort, and loss of appetite. The QT interval is a measure of the time required for the ventricles to repolarize after each contraction. It is measured from the beginning of the QRX complex to the end of the T wave. Normally that interval is 0.36 to 0.44 seconds, or 9 to 11 boxes. Most commonly used medications can prolong the QT interval, but it rarely leads to torsades and sudden death in low-risk patients on one QT drug. Watch for the highest risk patients, where torsades is more likely. This includes patients with a history of QT prolongation, bradycardia, acute MI, and low ejection fraction. Also look for hypokalemia and magnesemia, especially with new diuretic use, vomiting, and diarrhea. Females are also at higher risk due to a longer QT at baseline. Stay alert for meds known to prolong the QT, especially those associated with torsades. For example, think of methadone and amiodarone as red flags, particularly in a high-risk patient. Limit the QT risk by using lower doses of some med, such as no more than 40 milligrams per day of citalopram, or 20 milligrams per day for patients over age 60. Continue to watch for quinolones, moxifloxacin, levaquin, those sort of things. Macrolides, which is clarithromycin, antipsychotics like haloperidol, fluconazole, or ondansetron. Torsades is very rare, but possible in some cases. Try to avoid high-risk combos, such as 2 or more QT meds, or adding a med that interacts and increases levels of a QT med. These situations can create the perfect setting for a QT storm, such as an elderly woman prescribed ciprofloxacin for bacterial gastroenteritis with hypokalemia, and also given ondansetron for vomiting. Check a baseline EKG and monitor closely. Weigh risks of adding a QT prolonging med when the baseline QT is above 450 milliseconds, or especially above 470 milliseconds for men or women. Should be above 470 milliseconds for men or 480 milliseconds for women. Stop QT prolonging meds if the QT rises above 500. These patients are at the highest risk of death when taking QT prolonging meds. It can be very difficult to determine whether a specific drug is responsible for an observed adverse event. Other factors must be considered, such as underlying illness or other drugs. It can be hard to determine if an individual drug caused a reaction in the complicated patient receiving multiple medications. However, the temporal relationship of a reaction with regard to the administration of a new medication can be helpful. Also, biological plausibility, asking if the drug's mechanism of action makes this possible or likely, that can also be helpful. The bottom line is, even when in doubt about whether a drug caused the reaction, report it. Here are some questions to ask yourself when you are considering if a symptom is an adverse drug reaction. Did the symptoms appear shortly after the drug was first used? Typically, symptoms do occur shortly after the drug was first used, but not always. Do symptoms abate when the drug was discontinued? Do symptoms reappear when the drug was reinstituted? With muscle aches with statins, we often discontinue the drug for 2 to 4 weeks and reevaluate. If considered safe, we can reintroduce the drug and see if the symptoms appear. Symptoms usually occur within 4 to 6 weeks after starting the statin, but actually can occur years after treatment. A couple of other questions that can be asked include, is the illness itself sufficient to explain the event? Are other drugs in the regimen sufficient to explain the event? The answers to these questions can reveal a temporal relationship between the presence of the drug and the adverse event, which can increase the likelihood that it is an adverse event. The questions can also reveal if the adverse event can be explained by the illness itself or by other drugs the patient's consuming. If the adverse effect can be explained by the illness or other drugs, then it is likely not due to an adverse drug reaction. Half of all new drugs have serious adverse reactions that are not revealed during Phase 2 and Phase 3 trials. Most new drugs are approved with an average of 1,500 patient exposures and usually only for relatively short periods of time. However, some drugs cause serious adverse drug reactions at very low frequencies and would require many more exposures to detect the reactions. Thus, be alert for unusual responses when giving new drugs, because newly released drugs may have as yet unreported adverse effects. A suspicion of an adverse drug reaction should be reported. A healthcare provider does not have to be absolutely certain that a drug caused a reaction. All reports contribute to the heightening of the awareness of FDA safety scientists as they monitor all of the evidence to evaluate the potential for drug-related toxicity. The bottom line is, even when in doubt whether a drug caused the reaction, report it. Black box warnings are the strongest safety warning a drug can carry and still remain on the market. The purpose of this warning is to alert prescribers to potentially severe side effects and ways to reduce them. A last note warning on fatigue. Your electronic prescribing system is programmed to catch as many problems as possible, but crying wolf too often can backfire. Up to 90% of alerts are now simply overridden, and for good reason. Only one serious interaction is prevented for every 2,700 computer alerts. Drug class alerts can be inappropriate when they only apply to specific drugs in the class. For example, not all macrolides interact with simvastatin, and not all SSRIs decrease the efficacy of tamoxifen. Serotonin syndrome alerts come up a lot, but it's very rare. Don't combine an MAOI with other serotonergic drugs. And try not to combine linolazid, which is Zyvox, with an SSRI or SNRI. QT interval alerts are common. Actual torsades is rare, but it can be life-threatening if it does occur. Watch for high-risk drugs in patients at risk, women, elderly, or patients with heart failure, bradycardia, low serum potassium or magnesium. Use an alternate drug for high-risk patients. Continue to pay attention to the biggies. Potassium-sparing diuretics with ACEs or ARBs. TMP SMX with warfarin or potassium-boosting meds. Clarithromycin with digoxin or some statins. Oral contraceptives with enzyme inducers. and interactions with narrow therapeutic index meds such as warfarin or levothyroxine. I realize that this is a long module. I am hoping the others will be shorter for all of our sakes.